Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, and today we have a special episode. We're taking another break from the rules, and I'd like to dedicate the next two episodes to a very important topic, pediatric respiratory emergencies. And this is a very important topic for one single, very important reason. I always teach the residents, the medical students, the PAs. If you take 100 kids in dire straits, it's almost always a respiratory cause. Bad asthma leading to hypoxia, cardiac arrest. Bad bronchiolitis or croup leading to hypoxia, cardiac arrest. Probably the most common reason I get called to a room by a nurse urgently is because of a child with a respiratory complaint. So for us, those of us who take care of kids, we really have to know everything there is to know about pediatric respiratory emergencies. We'll be talking about croup today and bronchiolitis in our next episode. Let's get started. So I'll start by saying that I stand by what I said in the past, that for the most part, physical exam in the pediatric emergency department is oftentimes not particularly helpful. The kid is crying, can't hear anything, can't hear the wheezing, can't hear the lungs. If he's crying really badly, you can't even assess the respiratory rate, so it's often very clouded. However, I would say that with regards to respiratory emergencies, the physical exam is very important. So I think of the pediatric airway as simple, and I think of it as divided to two sections. Easy, the upper airway and the lower airway. And I think of the larynx as the midpoint between those two. So anything above the larynx is the upper airway. Anything below the larynx, well, guess what? It's the lower airway. And anything that causes obstruction in the upper airway is going to cause an inspiratory sound. We call that stridor. I encourage you to YouTube it. It's that funky sound when the kid is inspiring. Now, anything that causes obstruction in the lower airway is going to cause an expiratory sound, and we are all very familiar with that sound, that is wheezing. So again, simply put, inspiratory is a problem in the upper airway, we call it stridor. Expiratory is a problem in the lower airway, we call it wheezing. Easy, simple, some but very few exceptions. Knowing that really helps you out a lot. So once you look and listen to the child, you can figure out where the obstruction is, and where you go from there is usually very straightforward, with very specific medications for the upper airway, namely racemic epi, with very specific medications for the lower airway, namely albuterol, Atrovent, and all the bronchodilators. So once you look and listen, you can really figure out where the child is and how to help him out. So let's move on and talk about some very common reasons for airway obstruction in the upper and lower airway. Starting with the upper airway, I think we're all very familiar with the viral croup, also known as laryngeotracheal bronchitis. I think it's important to be familiar with that name because on an exam, croup may not be one of the answer choices, but laryngeotracheal bronchitis will be, so be familiar with the nicknames as I call them. And this is a very simple condition, basically viral infection that kind of settle in the larynx, causing inflammation, swelling, and narrowing of the larynx, and causing that funky, barky sound. It's always viral, so please, no antibiotics. And for some reason unknown to me, males tend to be a lot more affected, twice as affected almost. And it's almost always a toddler 6 months to 3 years of age who presents in the winter. I encourage you to entertain the possibility of a different diagnosis causing upper airway obstruction when it's not the winter, the kid has no runny nose, no virally like symptoms. Think about something like a foreign body or some other etiology causing obstruction of the upper airway, because viral croup is very unusual to see in the summer. And if the child has no runny nose, no congestion, no viral symptoms, a term that we pediatricians like to use, it's really unlikely he has viral croup. But anyhow, viral croup, I always tell parents, comes in two different flavors. All kids with viral croup have a barky cough, and it's that barky dog seal-like sound. Some kids with croup, and to my understanding, that is about 10%, have the barky cough and stridor at rest. What is that? That is that inspiratory sound when the child is resting. He's not crying, he's not running around, he's really not doing anything. And that distinction is very, very important. We'll get to that later. With regard to the barky cough, I think it's very important to keep in mind you gotta ask. Oftentimes, I leave the room about a child with respiratory complaint and I realize, oh, I forgot to ask if the cough is barky like. I go into the room and I get something like, that's exactly how it sounds, doctor. How did you know? Well, I can tell you from my experience, once you ask, Mom, does little Johnny sounds like a dog or a seal when he coughs? They go like, that's exactly what it sounds like. How did you know, doctor? Well, if you ask, it's a slam dunk. If the kid is not coughing now, I'm hoping that during the exam, when I look in the ears or something like that, they start crying and then you can hear it. And again, like I said, it's almost always a boy, toddler in the middle of the night. The management of those kids is very simple. Kids with barky cough and nothing else needs a dose of steroids, and there's been a very big debate in the literature as far as I know about which kind of steroids and one dose. To my understanding, dexamethasone, prednisolone, tomato, just give the kids some steroids. Even with regards to the dose, the classic dose has been 0.6 mg per kg, but there have been several studies showing that 0.15 mg per kg or 0.3 mg per kg is just as good. PO, IM, pick your choice. Certainly, if the kid is very tachypnic, IM would be preferable. If the kid can take PO, go ahead and use the mouth. No other meds, nothing else. I always tell the parents this is a viral illness, so treat the fever as needed only. There's nothing dangerous or serious about fever. And if little Maggie is happy with the fever, she's playing, happy, smiling, and drinking, so be it. I tell them to come back if the kid develop respiratory distress again or if that stridor at rest comes up again. Now, if the kid has the barky cough and stridor at rest, those kids represent slightly more severe version of croup and they need your attention right away. So those kids will need racemic epinephrine in addition to the steroids, and those usually get observed in the pediatric emergency department for 3 to 4 hours. To my understanding, there's about 6% chance that they will need another racemic epi within that time period, and that is something you want to know about. And I must say, I think all my colleagues and all of us pediatric emergency medicine physicians out there usually admit the child if within that observation period they needed 2 racemic epinephrines. Now remember, I told you, you got to see if the stridor is at rest. The reason is because once you give racemic epi, you really condemn the child for being observed in the pediatric emergency department for 3 to 4 hours. And it's not something I take very lightly. So if the kid has stridor at rest only, he gets racemic epinephrine. Otherwise, it's steroids and goodbye. And if I gave racemic epinephrine, the child is better, no stridor at rest. I observed him in the pediatric emergency department for 3 to 4 hours. No rebound, looking fantastic. He is going home. Again, good anticipatory guidance. Mom and Dad, we did a lot of treatment for Johnny today, but please realize he's still going to have quite a few symptoms for the next few days. So little Johnny is still going to have runny nose, congestion. Hopefully the cough will get better in a day or two, but he should not be having difficulty breathing. And I know it kind of sounds funny, but my personal experience having worked in Pennsylvania and Massachusetts in the cold weather, I tell them that if their child wakes up at night with difficulty breathing and that stridor at rest again, take him to the kitchen, open the freezer, let him breathe that very cold air, and then come and see us. Again, my personal experience, and those of you who work in cold states know exactly what I'm talking about. Kids with croup oftentimes wake up in the middle of the night with some difficulty breathing, stridor at rest. They come to the ER. All of a sudden, they feel fantastic, looking fantastic, and the parents feel very bad. I tell them, everything you did is just right. The cold air outside, and in the winter in Massachusetts and in Pennsylvania, where I did my residency and fellowship, it might as well be the freezer. It's like 20 degrees, and that cold air causes very temporary vasoconstriction, and the child feels and looks and sounds better. Keep those kids in the ER for half an hour, and they're back to square one. So that's why I tell the parents, take him to the kitchen, open the freezer, let him breathe that very cold air, and come and see us. It's almost like a very temporary racemic epinephrine treatment. Just to circle back with regards to the steroids debate, again, prednisone, prednisolone, dexamethasone, how much? A lot of debate, a lot of uncertainty out there for the most part. So as long as the kid gets some steroids, I'm good with him going home. Remember, the only way dexamethasone can kill a child is if he drowns in a pool full of it. Now, as always, important to keep in mind, some kids with croup, although it's a benign disease, do have to get admitted. So let's review the indication for admission for all kids with respiratory illnesses. If the kid is hypoxic, he has to come in. There is no oxygen therapy at home. If the patient is not tolerating PO, fluids, we're not really worried about the diet for the next few days, he has to come in. If the patient is in respiratory distress, which is really a subjective measure, he has to come in. So all kids with respiratory illnesses, if they're hypoxic, not tolerating PO fluids, or working hard to breathe, have to be admitted. Specifically with Croup, I teach the residents something I call the Croup exclusive. If the patient got 2 racemic epinephrine doses in the ER, I admit them. Now, every once in a while, and thank God it's a fairly rare occurrence, I see a child with really bad croup. So it's usually a 2 or 3-year-old male who presents with stridor at rest and respiratory distress, but this kid has high fever. Usually with croup, I see low-grade fever. This kid is really not very well appearing, looking toxic. Usually with viral croup, they're not toxic. I give that kid racemic epinephrine, and a few minutes later, he needs another one, and again, and again, and again. In those kids, I entertain the possibility of the not common but worse complication of croup, also known as bacterial tracheitis, and this is unfortunately not a disease I can diagnose definitively in the pediatric emergency department. It's more of a clinical diagnosis. Those kids need vancomycin and ceftriaxone, treating for the most common bacterial infections causing bacterial tracheitis, and in those kids, I call for help and I intubate the child. The reason being, because although I'm a pediatric emergency doctor and I think of myself as an airway specialist, I'm not really the specialist when it gets to the difficult airway. That I leave for the anesthesiologist, and I recognize the fact that I need some help. Every time I intubate a patient with an upper airway obstruction, that means 2 things for me. Number 1, call the specialist, the anesthesiologist. Number 2, get 1 size ET tube smaller. So if you think the child needs a 5.0, get a 4.0 just as a backup. Now, there are many ways to figure out what size tube do you need. Most commonly, people use the formula age divided by 4 plus 4. I gotta be honest, I majored in math and I'm a math nerd. I can't do math under pressure. So the way I figure out the size tube that I need is by having memorized the following phrase. 4 if you're 1, 5 if you're 4, 6 if you're 8. Say that 17 times and you'll remember it forever. 4 if you're 1, 5 if you're 4, 6 if you're 8. So if the patient is 1-year-old, I get a 4.0. If the patient is 4 years old, I get a 5.0. If the patient is 8-year-old, I get a 6.0. And then I take it from there. Easy to remember, easy to say. Personally, I don't do math very well under pressure. And there you have it. My approach to the pediatric patient with viral upper respiratory infection, croup. I hope you like the episodes. I hope you tune in next time. We'll be talking about lower respiratory obstruction, namely bronchiolitis, which is probably the most common cause for it. Feel free to email me with any feedback or any suggestions you have or requests. Check out www.pemrules.com. Would love to hear from you. I hope you like this little outro. Wrote it back in high school. It's been many years. I've been playing it since.